Hello, everyone. Thank you for joining me today for the webinar that we are hosting on FHO optimization and outside use management strategies. My name is Miral Sanassian. I am a consultant on the healthcare consulting team here at Cirrus, and I will provide you with my contact details at the end of this webinar so that if you have any questions as we go along, you are more than welcome to contact me directly, and I would be happy to help you with any questions you may have on optimizing your practice or improving outside use. So let us begin. Just a little bit about Cirrus as we get started. Cirrus Consulting Group is a small firm located in Toronto. We're about 50 employees here, and what we do is we provide practical business solutions to allow healthcare professionals to do what you do best, which is provide quality patient care. We are composed of two units. There's the office lease negotiation team that works with dentists and physicians across North America with their lease negotiations. And then there's a healthcare consulting division, my team, which supports family physicians in Ontario with billing and practice optimization, both on the individual and the group level. So a couple of quick facts today. Family physicians are now better compensated in Ontario than anywhere else in Canada. More than 75% of physicians say their pay does not align with the care they deliver, which is a gap we really do want to close when you are doing the work. A lot of physicians believe their access bonus will never be positive, and time again, we've come across these scenarios, worked with physicians and groups, and this absolutely is possible. Your access bonus can move towards the positive. And Ontario physicians are generally not strategic in how they are paid due to the widespread lack of clarity around the OHIP funding models, and that's something we often do is we really do a big education piece on the OHIP funding model that you work in. So moving into the FHO and the purpose of today's program. The purpose is to guide you through the FHO income streams in order to increase your understanding, income, and flexibility, to help you better understand where your practice income is coming from, and to leave you with a much clearer idea of what the FHO is all about. So we'll start with the FHO income streams. How are you paid when you practice in the FHO model? The Family Health Organization is a payment model where physicians get a monthly prepaid payment for having patients on their roster. So it really is a salary payment you get each month for having X number of patients on your roster and caring for them. And the point is to provide access to your rostered patients as opposed to having them come through and seeing them one after the other. So it really is all about providing access as opposed to the throughput when we're looking at the Family Health Organization model. If we look at the FHO income stream breakdown, on average, we see that there's about 77% coming in through capitation payments. Then you move into your fee-for-service payments, your access bonus, shadow billing, preventive care, and your special premiums. And we'll walk through these income streams today in a bit more detail. So starting with the capitation payments. On average, the capitation for having a patient on your roster is $215 per patient per year. This is adjusted based on the age and the sex of your patient, and it's composed of two capitation payments. There's the bigger portion, the base rate payment, and then the smaller portion, which is the comprehensive care payment, which also existed and does exist for physicians that practice in the family health group model. So the capitation payments, that monthly prepayment you're receiving, that salary that you're receiving for having patients on your roster, is there to cover a list of services that are deemed to be comprehensive, to provide comprehensive care. There are 126 fee codes which represent this, the majority of comprehensive care services, and these are the in-basket services that are covered for by your capitation payments. So for example, billing A001, A007, these are all in-basket codes for which you receive capitation payments for. Everything else outside of those 126 codes are out-of-basket services, and you will, on top of the capitation, receive 100% of the fee-for-service value for patients that are on your roster. So as we've put there, diabetic care is an example of an out-of-basket service when you're practicing in the FHO on your enrolled patients, because it's more complex care that you're providing. This is just a breakdown of the capitation payments within the FHO. You'll see the females and the males. And you'll see the payments change per patient within the different age groups and within the different sex breakdown. And this really goes to show that you will be receiving a higher capitation for, let's say, a 65-year-old female as opposed to a 17-year-old male, because the care demanded from you is significantly different. Roster management. Effective roster management is extremely important when you practice in a family health organization model, because so much of your income stems from your capitation payments, which as a result come from the roster that you've got. So roster management is ensuring that you've got a good roster composition, that your ministry roster and your EMR roster align. And that's extremely important, because what you want to make sure that the ministry is catching everyone that you actually have as roster to you on your EMR, so that you're capturing the capitation that you are eligible for. And then building a roster that meets your personal goals. Every physician, every practice has a different need, and so you want to make sure that your roster reflects not only the composition but also the number that that suits your practice style. So whenever you do bring on patients, do make sure that you submit the Q200, you get them to fill in the necessary forms, and that you submit the new patient incentive fee that sort of aligns with the patient that you're taking on. Keeping in mind that you are eligible for 60 of the Q013 new patient incentive fees. However, this will be discontinued along with a number of other new patient fees coming June 1st, 2015. But it's good to keep in mind that you bring on a patient and you enroll them accurately so that they do go onto your roster and you have a strong roster composition. So those are the breakdowns for the Q013. As I said, they still exist, but they will be discontinued in a couple of months' time. So you will be billing the Q200 with any appropriate new patient fee that remains. The financial impact of having a roster that accurately reflects the patients that you're actually seeing is substantial. As you can tell, even catching 25 patients or adding on 25 patients makes a difference of $5,000 annually to your base income. And so one of the things that we always work with our clients on is ensuring that the patients they're seeing are actually rostered. We do roster reconciliations between your ministry base rate report and your EMR at least once a year, and this really does make sure that you capture, that you actually are capturing the patients that are on your roster and receiving the appropriate capitation payments for them. So definitely a roster reconciliation at least once a year is a great way to ensure that the ministry is capturing the patients that you are actually seeing. Moving on to fee-for-service billing. When it comes to family health organization, you've got your enrolled patients and your non-enrolled patients. So when it comes to any out-of-basket service that you provide for your enrolled patients, this is where you're going to be getting 100% of the fee-for-service value. If you're billing any in-basket codes, so for example, the A007 on your enrolled patients, you get 15% plus the capitation. If you're billing any out-of-basket service, for example, the K030 for diabetes management, you will get the capitation plus 100% of the fee-for-service code value. When you see patients that are not enrolled to you, then whether you're billing in-basket services or out-of-basket services, it's as if you're seeing a patient fee-for-service, and you will get 100% of the code value for both the in and out-of-basket codes, keeping in mind that you will not get the capitation payments for them. There is a hard cap. It does not apply in the first year that you practice within a family health organization model, but there is a hard cap for in-basket services that you provide to non-enrolled patients. And that's because the ministry is encouraging you to enroll the patients that you see often that you're providing comprehensive care for. The group hard cap is about $60,000 for in-basket services billed to non-enrolled patients per year per physician, but it is pooled across the group. So if one of your team members bills more and one of you guys bills less, then as long as you don't hit the sum of the group cap, then it's okay. And the majority of groups we work with have never had the issue of reaching this hard cap. But it's good to be aware of it. When you're in a family health organization, it is good to be aware of the out-of-basket services that you can bill, because you are paid 100% of the fee code for them, and you want to make sure that you're billing appropriately. So some of the key areas that we'll look at: diabetes management, we'll look at smoking cessation. The after-hours billing is also a great area. So we'll look into these just because you want to make sure that you're billing appropriately for the care that you're providing. When we look at diabetes management, a lot of physicians that I work with that have moved, for example, from a fee-for-service or family health group model and switched to a FHO are billing the A007 when they do diabetic care. However, when you're in the family health organization model, that A007 now falls within the in-basket services for your enrolled patients, and you get 15% of the fee code. However, if you switch your billing and you bill the K030, which you can bill up to 4 times a year per patient, then you're billing an out-of-basket code that's specifically for providing diabetes management care to your patients. Once you collect enough information, typically after 3 or 4 visits, then you can fill in the diabetic management flow sheet, and then you can bill the Q040 code once a year, which also gives you an incentive for providing diabetic care to your patients. So typically, assuming you bill the out-of-basket codes for diabetes management, the K030 4 times a year and the Q040, the maximum per patient you can get is about $216.80. Within an average size practice of 1,500 patients, you typically have between 121 and 141 patients with diabetes within your enrolled patients. And that in and of itself can bring in an additional $26,000 to $30,000 purely by switching your billing to the appropriate diabetes management billing codes. So add that to the average capitation per patient you get for having them on your roster, and the diabetic patient value goes up to about $50,000 to $60,000. So a small switch in your billing for the care that you're providing can really go a long way. A similar situation applies when we look at smoking cessation. You can bill the E079 when you have that initial conversation about smoking cessation. It's billable once a year, and it can be billed along with assessments. And then if you were to see that patient twice following that initial visit within a calendar year, then you can have a follow-up conversation on smoking cessation. And when you do have those follow-up conversations, you can bill the K039 with the Q042 up to twice a year for enrolled patients. And again, this combination for providing care to your patients that are working to cease their smoking, it can bring, again, an additional, it's definitely a great incentive for you. If the maximum you could get per patient annually is around $97, and you have about 155 patients in an average practice who undergo smoking cessation, then you've got about $15,000 coming through the fee-for-service billings, because they're out-of-basket codes, the E079 as well as the K code and the Q code. And then along with the capitation you're getting per patient when they're enrolled to you, the total patient value when you provide care for smoking cessation goes up to about $48,000. So small adjustments to really cater to the care you're providing can really make a difference when you work in the family health organization models. So overall, it is good to be aware of the out-of-basket codes to make sure that you're billing appropriately for the care that you're providing. Now we're going to go into access bonus, which typically composes of about 5% of an average FHO physician's income when they capture it. And we'll look into the patient management and outside use more closely as well. So the Access Bonus program is all about providing access to the patients, to your patients and the patients of your FHO members. Outside use really is a daytime access issue. We typically see it highest between Mondays and Fridays. So you really do want to make sure that there are same-day urgent appointments available to you, for your patients each day, so that you can cater to those to the last-minute needs. Do assess the needs of your patients and review which days of the week seem to be busier with walk-ins and call-ins. One of the best ways to improve your outside use is to know which days really are highest, and that's one of the things we do with the analyses that we run to support physicians with having a better idea of the flow and when their outside use peaks across the weekdays. Collect emails of the patients walking through the door, or just constantly inform patients that you are there, you and your FHO colleagues are there to provide care for patients, and they have access to you, to your after hours, to your FHO colleagues when they are covering the after hours shifts. So there really is a great availability for them to come and access you in your clinic and your colleagues as opposed to going elsewhere for care. So one of the ways of doing this is to provide extra hours, open more slots on busier days, less on quieter ones. So for example, if you notice that you have high outside use on Wednesdays and you've been booking a lot of longer appointments like physicals on those days, then chances are you can move your physicals to less busier days, and that in and of itself will open up a couple more slots for you on that day. The bottom line is that patients do need access, and we often work with the groups and the physicians we work with in order to enable, to look at the data and enable you guys to make sure that you can create a better balance within your work week to cater to the need for access. Managing outside use. It is hard to control patient behavior. A lot of the problem is that patients are not aware of the outside use program and the impact that they have when they go elsewhere to get care. It could be that there are no appointments, or that they were unaware that there were after hours appointments to them. So there really is a big education piece that goes with managing outside use and capturing your access bonus. So really do have you and your front staff encourage patients and let them know that there are services available to them to come and be seen when they need to if they have urgent medical needs. So one of the things that we'll do, is in order to analyze the data, we'll help determine which patients to move from roster to the fee-for-service bucket. And again, if you move a patient from being on your roster to being seen fee-for-service, the only change is an administrative one. So you can still see the patients, you can still care for them, but you will be seeing them, you will be billing them 100% fee-for-service as opposed to the combination of in and out of basket codes and your capitation payments. For any patients that are seeking care outside heavily, you could always deroster them back as early as 6 months. Or their earliest date of outside use. Since it is a daytime access issue, we want to make sure that there are same-day urgent appointments available when you are in the clinic, and that your front staff is aware of the FHO program and make an effort to educate the patients about what it means to be part of a family health organization and the benefits with it. And one of the things that we will monitor when we look at outside use data for the physicians we work with is we'll look at not only the days of the week it happens across and the codes that are popping up and the heaviest users, but are there any red flag codes? And that's what this goes into is if patients are using any of the following services, this typically leads to really heavy outside use because it tends to lead to an ongoing relationship with other physicians. So for example, if you see focus practice assessment codes for addiction medicine, typically that's a code that you'll see popping up many, many times, and it's often a relationship that's ongoing with the physician that they're seeing. If there's any for example, palliative codes or psychotherapy codes. So it's always good to be aware of these red flag codes to make sure that, to have a better idea whether the patient is going to continue receiving these services externally outside of the group, or whether it's a one-off, or, if it's sort of a temporary situation and then they will stop and be coming back. So these typically lead to high outside use because A, the behavior is repetitive, and also the dollar value is quite high, and it makes a big impact towards your access bonus potential. So going to derostering, which we touched upon, when you are trying to capture your access bonus potential, you do want to make sure that you've got the right patients on your roster, and if there are those that are contributing really heavily to your outside use, either by constantly going to walk-in clinics or going and receiving addiction medicine services from elsewhere, you may choose to deroster them and just change the administrative relationship between you and the patient, if this will move them from the capitation to the fee-for-service income stream. And just logistically, what will happen is that if you were to go back 6 months, for example, you would be deducted the capitation payments that you were paid across those 6 months while you still had them on your roster. Any shadow billing that you had provided, so any A777s, let's say you'd billed on the patient, will be topped up to the full fee-for-service value, and all the outside use will be removed. So you'll get a bigger portion of your access bonus. And moving forward, you can still provide the same care, but on a fee-for-service basis for the patient. So when we work with physicians on their outside use management, we have reporting tools that we use in order to compile all the data that you get from the ministry as well as other data that we pull in order to support you with the process of understanding who are your heaviest outside use contributors and how we can help you capture your access bonus both individually and as a group. So we will pull all that information together, and then first of all we look at it on a high level. So we look at what are the heaviest codes that are contributing to your outside use based on all the information that we've looked at. And then we'll look to see which of the days across the weekdays are your heaviest days of outside use, and is there any changes we can do with your we can help you with your scheduling in order to cater to the days where the need is highest. And that goes back to perhaps scheduling longer appointments on less busier days and opening up more slots on your really heavy days of outside use. Next, we'll look at your top contributors to outside use. Again, compiling a number of months of data and looking at their capitation that you've earned, looking at their outside use behavior. We'll pull your top 20 patients, and then we'll provide you with the prorated capitation so far, which is the income you've received. What is the outside use that they've incurred so far? And where do you stand? Who are really your heaviest contributors to outside use, and what positive impact will it have if you were to deroster them and see them fee-for-service? Keeping in mind that you can go back up to 6 months if need be. So we compile this information to provide you with a lot more visibility into who are your highest contributors and what really are they going outside for. So we look at the income and we look at the cost so that we can really see the net benefit of keeping a patient on or off your roster. And then we move into more detail and we look at the number of services that they've incurred across how many months of data, across how many months have they been incurring outside use. We'll look at when the earliest outside use date is, and now we also include the latest outside use date, so you have a better idea of the time frame of your patient's behavior, and which will give you a better idea of whether or not it is better to keep this patient on the roster or see them fee-for-service. And then we'll look at the top codes that were billed on them. And this is typically where those red flag codes pop up, such as addiction medicine or pain management. And you really want to make sure that you catch those patients and you can go and deroster them if need be to the earliest date of their outside use, or 6 months, whichever is closer to today's date. So what we'll do is we'll really combine all this information, and we run these analyses for physicians that we work with to support you in managing your outside use and inevitably capture a bigger chunk of your access bonus. Once you have more visibility and a more complete picture of what your patients are doing when they go elsewhere for care, then it's more empowering and it enables you to make a more educated decision on who to see on your roster and who to see fee-for-service. So now moving into the other income streams in the FHO, we'll look a little bit into preventive care. So preventive care is roughly about 2% of the FHO physician's income, and what you've got is your 5 categories. They haven't changed, and you're eligible for up to $12,800 available in your preventive care bonuses each year. Assuming you meet the different targets for screening or for preventive care, you will get the bonus accordingly. Typically, the ministry fiscal year will end in March 31st, and you've got about 6 months to submit your preventive care thresholds that you've reached in order to receive your bonus. It is a time-consuming exercise, but absolutely worthwhile when you're providing preventive care to your patients to go through the exercise and submit your preventive care thresholds that you have reached for the patients on your roster. In about April, you'll be receiving your target population reports. It does come twice a year, typically in October and then again in April. And so once you receive them in April, you can get to work, and you'll have typically until September to submit your preventive care targets. And this is just a little overview of the reports that you typically get, which shows you the patients that qualify for your different categories and whether there is a known service date for their care or an excluded date. And then if you supplement this with your own records, then you'll typically have a complete list of the patients that have received preventive care service from you, and to receive your preventive care bonus. Special premiums and CMEs. Now this is again about 2% of the average FHO physician's income. Keeping in mind that the CMEs will be discontinued as of June 2015, you did up to now have a $2,400 bonus potential. And so if you have not maxed out on your CMEs, then definitely a great idea to do so up until the end of fiscal, which is March 31st, 2015. And when it comes to the special premiums, you've got 8 categories that you can receive additional bonuses for, depending on the work that you do in your clinic style, your practice style. So that has a $37,000 bonus potential when you're in a family health organization. These are the 8 categories in the family health organization. So if you do hospital work or home visits or any prenatal work, it's a great area that, if you look at the codes that qualify, if you are billing any of them, then if you're doing the work, it's a great way to receive additional incentive for providing these elements of care to your enrolled patients. And this typically runs within a fiscal year, so April 1st to March 31st, in order to reach the different thresholds for these bonuses. With regards to CMEs, you do have the $2,400, which is the equivalent of 96 credits or 24 hours of CMEs. There is a max on the Main Pro M1s that you can bill. Typically 80 out of the 96 credits can be Main Pro M1. The remainder can be either the Q555, Main Pro C, or the other category. So I highly recommend to look into your remittance advice and look to see if you have any credits that are remaining this year, and if so, then to maximize on your CMEs and your CME allocations, since this will be discontinued down the line. And typically, if you haven't used up your 24 hours from the previous fiscal year, they do carry over for 1 year. So if you were to look at the current balance, which is on your remittance advice, the last line item of the picture we've put here, that's where you can tell the total number of credits that you do have left, including those from any carryover you may have had. So some of the key takeaways from our webinar today on FHO optimization and improving access bonus capture and outside use is to ensure that the patients you're seeing are actually on your roster, since the capitation payments is the largest source of income for you when you're in a family health organization model. Do remember to submit the corresponding rostering incentives and the rostering codes, so the Q200 and the Q013 or any other relevant patient incentive fee that will still remain. For preventive care, do submit your tracking and exclusion codes. It will make your life much easier when you are calculating your preventive care thresholds at the end of your fiscal year. And do remember you have until September usually to submit them. Be aware that outside use is a daytime access issue. It's not so much in the evenings or the weekends. So do ensure that you provide access to your patients, you and your group provides access to your patients from Monday to Friday in order for any medically necessary visits in order to better manage outside use. You do have the ability to deroster retroactively upon making an informed roster management decision. And most importantly, if you have, we are here to help. We work with a lot of groups on optimizing their practice as well as improving their access bonus capture rate. So please feel free to reach out to us if you have any questions whatsoever. And I will move us into a bit of an example of what we do and how we can help. So typically, the majority of physicians we speak to are really looking for a better balance between the income, the work that they're doing, the flexibility they have in their schedule, and the work-life balance. So it really is, by working more closely with them, we try and, we sort of support this, the combination of this process coming into effect. And so we will always have FHO education sessions, not only for the physicians we work with, but for their staff, because we've noticed that when the staff are better educated on the models that physicians work with, it really does support the whole practice optimization element for the physician. So we do offer education sessions to both staff and physicians with groups that we work with, or individuals for that matter. Governance agreement, we do a lot of work on governance agreements to support you and your group in having a strong agreement in place that reflects the needs of all physicians in the group that you go by. Group accounting, we manage group banking, the distribution of funds for a number of groups that we work with. So that's a big element we take off your shoulders. Income optimization. We manage your FHO income and income streams on a month-to-month basis to make sure that you are properly compensated for the care that you are providing, and that if there's any discrepancy, we know we catch it immediately and we can investigate it further. And we do have a team in place here that's always there to support you and answer and help you with anything you may have. And the way and how we help is we really do, we utilize your data in order to optimize your practice so that we have concrete information to support you. So we'll provide you with outside use analyses, we'll provide you with a breakdown of your RA so that you can see the different income streams. We will do roster reconciliations to make sure that your ministry list does actually reflect those that you have enrolled to you on your EMR. We will look at your premiums, your special premiums and bonuses twice a year to make sure that you are capturing the areas relevant to your practice style. And so we constantly look at the data and we look to see how you're performing, and we stay on top of it to support you in maximizing optimizing your practice and having a smoother practice style moving forward. And optimization is tackled step by step. So we do look at each of the income streams, and we'll chat with you to find out which of the streams, if any, are your particular areas of concern that you want to improve on. So we'll make sure that you're capturing your capitation payments to the best of your ability, you're billing properly, especially with your out-of-basket codes, that your access bonus is being captured to the best of your ability, making sure that your shadow billing is consistent, and that you're capturing your preventive care and special premiums. And we'll typically provide a 12-month breakdown of the activities that we will do once we speak with you and work with you, so that we can make sure that we support you with your practice optimization across the timeline we work with you and your group members. Our practice development program is $425 per physician per month. We work either one-on-one or with the entire team, and we have seen an average income increase of about 12 to 16% for physicians that we work with, and higher performing FHOs at the end of it. So if you have any questions whatsoever on the webinar, or any questions about optimizing your practice, please feel free to contact me. My contact details are on the screen, and I've left you with my direct number. I would be more than happy to speak with you and support you with your FHO optimization and capturing your access bonus. Thank you for taking the time to listen into our webinar today, and I hope you have a wonderful day.